Pleasure to be here and talk to you about one of my favorite topics to speak about, ADHD. By the way, it's all called ADHD now. ADD is an okay name to use. It's an old name. We won't take time to explain the change. I guess someone told me that an expert is somebody who carries a briefcase and comes from at least 1,000 miles away, and so I'm not an expert on ADHD for purposes of this morning. So we're going to be talking about ADHD and its relevance to you and yourself, your family, and perhaps your employees. If this morning's talk was about the fact that energized employees increase productivity, I suppose my talk is about over-energized employees reduce productivity and what you might want to do about that. For professional and ethical reasons, I want to disclose that I do a lot of speaking on ADHD. Some of those talks are industry sponsored. It's a struggle for me today to talk to you about ADHD, not for the usual reasons. I've got a real problem and I need your help. Because I do a lot of speaking on ADHD, I have a lot to say about ADHD, and I'd like to tell you all that I know. I've been given a half hour. My struggle is, what am I not going to tell you? Because I have to fit everything I want to say into the half hour. So I've chosen to mix a little bit about what I think you want to know and mix it with what I want you to know, and perhaps my colleagues across the country would want you to know about ADHD. So I'm going to have to speak very quickly to get everything in, and I'll ask you to listen quickly, and we'll get along just fine. We're going to overview very briefly what ADHD is. I have to do that when we're talking about ADHD, every time I talk about ADHD, because unfortunately there continues to be a lot of myth about this disorder and its treatment. So I want to make sure we're all on the same page about what it is we're talking about before we move on to talk about its impact on individuals' lives, specifically in the workplace, but generally as well in families and society. And then we'll talk about treatment, and the treatment flows, of course, from our understanding about what ADHD is and what it's not. ADHD is diagnosed based on specific criteria that have been scientifically evolved and will continue to be evolved as the field continues to do research onto the nature of the disorder and what distinguishes it from individuals who don't have the disorder. Currently, somebody is diagnosed with ADHD if they have problems with inattention, and there are specific symptoms that a clinician will look at, specific symptoms of inattention and or symptoms of hyperactivity and impulsivity, and the and or is important. There are three kinds of ADHD. ADHD where you don't have problems with hyperactivity, ADHD inattentive subtype. There's ADHD hyperactive impulsive subtype where you don't have problems with inattention, and then ADHD combined. That's important because hyperactivity and impulsivity is not always necessary in order to have a diagnosis of ADHD. Somebody can be very calm, appear to be lazy, and have ADHD because they have challenges with inattention and distractibility. In fact, that's more commonly the case in adulthood than to have ADHD with hyperactivity. The opposite is true in childhood. There's a shift that occurs. Of course, just having symptoms of inattention and hyperactivity aren't enough to have the diagnosis of ADHD. For it to be ADHD, it's something that should have always been there. If I'm assessing an adult and wondering whether they have ADHD and they tell me about problems with focus, concentration, distractibility, my next question is, how long has that been true of you? I'm listening for, it's always been true of me, at least into early childhood. ADHD that appears for the first time at 25 years of age is not ADHD. Unfortunately, as we'll show, it's commonly first recognized at 25 years of age, but it should have been there all along. And of course, it has to occur in more than one setting. You don't have ADHD just at work at your desk. That's not ADHD. Having said that, it's the nature of attention challenges and we'll describe why if we get an opportunity. It's the nature of attention challenges that it is going to be more of a problem in some settings than in other settings. So it won't be the same problem everywhere you go, but it should follow you if it's something you have. And of course, if you have all of these symptoms of ADHD and you're doing just fine, we don't call it a disorder. There has to be some functional impairment coming from the symptoms. That's true of all psychiatric disorders. There has to be some problem coming from the symptoms for us to call it a disorder. And of course, we have to be confident that you don't appear to have ADHD only when you're depressed or only when you're anxious. It's probably part of your depression and part of your anxiety in that case. And that's how we decide if somebody has ADHD. So when we're talking about symptoms of impulsivity, hyperactivity, and inattention, this is kind of how it might show in an individual who is an adult. They might be the individual who has difficulty sort of sitting still, paying attention in a meeting, finds meetings not just boring and difficult, they're torture. Very difficult to maintain attention and focus. Issues with distractibility. Impulsivity commonly occurs in an emotional way. Problems with anger are very common with individuals who have ADHD, but it's not a seething, chronic anger, it's a reactive anger. When we say impulsivity, we're usually talking about behavioral impulsivity, acting without thinking. But we are learning that in individuals who have ADHD, adults in particular, it's very common for them to have emotional impulsivity, where the braking system on their emotions aren't working as well. So the person who sort of reacts very quickly has difficulty waiting their turn to talk, which can come both from being impulsive and from having a memory problem. What's supposed to happen in a conversation is you speak, and while you're speaking, I might think about what I'm going to say while I'm listening, and then I, in turn, say what I have to say. If I've got a memory problem, I learn that I need to butt in and say what I have to say before I forget what I'm going to say. And so somebody with ADHD might be experienced in the workplace as the person who's rude, impolite, difficult to have a conversation with. When they have something to say, they have to say it right away. They might interrupt meetings, fidgetiness, etc. The person who's chronically late. It's the nature of our attention system, as we'll describe, that it's easier to pay attention when something grabs your attention. And something will grab your attention if it's interesting or new or important. So one very common phenomenon with somebody who has ADHD is that they learn the skill of procrastination. 2 weeks before a deadline, it's not important, and it's hard to concentrate. The night before a deadline, they can concentrate. So some people, maybe you, say, well, I'm just one of those people who does better under pressure. I do better with a deadline. Again, you're just sort of learning that it's hard to pay attention if it's not grabbing your attention. The night before, it grabs your attention. So it's very common. In fact, this is an issue when I'm talking to clinicians, physicians about diagnosing ADHD. There's this fear that if they start asking about ADHD, they won't know who really has it and who doesn't. With adults, it's more common that an individual thinks they don't have ADHD and they do, than that a person thinks they have ADHD and they don't. Individuals who believe they have ADHD tend to. Not universal, but generally speaking, the problem is in helping people who don't recognize it. It's different than depression, isn't it? It's not difficult to tell somebody that they're depressed because they remember not being depressed. If you have ADHD, you've always had it. And you've never been anybody else, so you don't know what it's like to not have ADHD. It's just me. No, I'm not hyperactive. Ask somebody else. No, I'm not inattentive or easily distracted, because you just don't know what it's like to be anybody else. I'm often asked how early you can diagnose ADHD. I happen to get a hold of my ultrasound. Okay, maybe that's a little early, but If you have ADHD, you were born with ADHD. This is a disorder that is highly genetic, meaning that the chances of you having ADHD is determined 76% by your genes. This is way up there with disorders you see on the screen here. Very highly genetic. If you have it, you were born with it. This isn't a result of poor parenting, Sesame Street TV, bad teachers, etc. We also know that this is a very brain-based disorder. This isn't a character issue, a discipline issue. This is something in your brain. You have ADHD as a result of differences in your brain relative to people who don't have ADHD. This is a slide just illustrating the delay in normal development that occurs with individuals as a group with ADHD. There is a normal development that occurs from the back of the brain to the front of the brain, and that's delayed in individuals who have ADHD, resulting in underdeveloped frontal parts of the brain. The frontal lobe is underdeveloped, underactive, among other parts, in individuals who have ADHD. So this is very much a brain-based disorder, highly genetically influenced. I want to briefly describe to you the nature of our attention system, because I think this will help you get it, if you will, in terms of some of the confusing things about individuals who have ADHD. If you know individuals who have ADD, ADHD, you don't have to put up your hand if you have it necessarily. How many know somebody who has been diagnosed with ADD, ADHD, right? It's sometimes confusing for individuals, and the confusion results in sometimes people not getting diagnosed with ADHD when they do have it. Sometimes people with ADHD can concentrate very well, better than other people in certain situations, and why is that? And why do they have challenges focusing, paying attention, and ignoring distractions? It's easy to understand if you understand how the attention system in the brain normally works. I'm a bit of a computer geek, so I developed this slide. You like that? That's nice. So this is your brain on drugs. No, this. Your brain is made up of different parts, obviously. What we were talking about is the frontal lobe. Frontal lobe is very important as it relates to ADHD and attention challenges. But before we talk about the function of the frontal lobe, it's important to understand another part of the brain. The parietal lobe, located above your ears there, is responsible as the first gatekeeper for attention. It is responsible for noticing things. There's noises going on. Maybe your neighbor's making some noises. There's your memory of a conversation you had at the break. There's the pressure of this seat on your butt as you're sitting there. All of those things, as I mention them, come to your mind. It's not as if they weren't present in your brain to begin with. They were. They all are coming, all of that is coming at your mind, your brain, all the time. Your parietal lobe is responsible for noticing things. Things that might be bright, things that move, things that are loud. You notice things with your parietal lobe. This works fine in individuals who have ADHD. They have no problem noticing things. But, unfortunately, this just illustrates the fact that things that are loud and move and are colorful are very easy to pay attention to, which is why it's very common for individuals with ADHD to love gaming, as I do. So, your parietal lobe is supposed to notice things, but what's supposed to happen, unfortunately, is that you're also supposed to be able to pay attention to things that aren't very interesting. Bookwork, paperwork. You're supposed to choose to pay attention to things, whether they're interesting or not. You need to discipline yourself. That's where the frontal lobe comes into play. The frontal lobe is responsible then, the prefrontal cortex, for moderating that. It is responsible for tuning down things that are catching your attention and tuning up things that aren't catching your attention. Does that make sense? So things come at your mind automatically without you even thinking. And then your frontal lobe tunes out things that you don't want to pay attention to right now, the noises, the memories, the pressures, so that you can listen to whatever I might say that might be of value to you. But that's the frontal lobe that's tuning out things that are automatically coming at your brain. That's why individuals with ADHD have difficulty paying attention to certain things and find it very easy to pay attention to other things. It probably shouldn't be called attention deficit disorder. It should be called attention management disorder. It's hard to choose to pay attention to things that aren't catching your attention and choose not to pay attention to things that are catching your attention. It's hard to manage your attention. You're at the mercy of whatever grabs your attention. If I'm not grabbing your attention, something else will. And that's the challenge that presents itself at the workplace. How common is it? It's present in about 6% of kids and about 1 out of every 23 adults in the general population. In individuals who are at populations at higher risk, forensic populations, mental health populations, kids in care, the rate is much higher, probably about 20 to 30% of individuals have ADHD. So it is very common in adulthood. It's probably going to be more common in adulthood because this may be an artificial artifact of the fact that our current diagnostic criteria uses child language. There's going to be a revision of the criteria very soon, so we will probably see not an artificial, but a more accurate increase in the rate of diagnosis in adulthood because the diagnostic criteria will be more adult-friendly. Unfortunately, in spite of the fact that 1 in 23 adults has ADHD, most adults go undiagnosed with ADHD. It is usually not recognized. It's explained away in other ways in our society, unfortunately. There's a series of so what slides here. Why does it matter? Well, the fact is, this isn't, contrary to popular myth, just a yuppie disease where everybody wants to concentrate a little better and get better marks than they would otherwise get. This is a disorder that is associated with significant impairment. In fact, Barkley showed that relative to the community group and another clinical group with depression and anxiety, in all domains, individuals with ADHD have more significant functional impairment. This is a disorder that results in functional challenges. And it's an important one to be aware of. In fact, all of these things occur more common in individuals who have ADHD than in individuals who don't have ADHD. Challenges in relationships, driving accidents, difficulties with employment and work are very common. Problems with the law are more common in individuals who have ADHD than those who don't. You can imagine with impulsivity, etc., and other reasons. Other mental health challenges are more common. Early teen pregnancy, multiple relationships, divorce, etc. It's a disorder that impairs the functioning of individuals in their lives. What about the workplace? There's lots of data on ADHD in the workplace. There's an increase in absenteeism as a result of the ADHD. Individuals are more likely to miss work. As an aside, healthcare costs are twice that of individuals who don't have ADHD. The healthcare costs of family members of people with ADHD are twice those of individuals who don't have family members with ADHD. Again, this is a disorder that affects the person and their environment. Looking at reduced quality of work, the reduced productivity in general results in, as you can see, the relative reduction in days of productivity annually for individuals on average with ADHD. That is different depending on which work sector we're talking about. So looking at professionals, white-collar technicians, service industry, and blue-collar, you can see an increasing challenge in terms of total days of reduced productivity with ADHD. So this impacts the workplace when untreated and undealt with. So how is it treated? Well, it's treated as it needs to be treated. The science is very clear. Contrary to popular myth, there isn't any treatment available today that works as well as medication works to treat ADHD. That's very clear. For some individuals, medication doesn't deal with everything that needs to be dealt with in their ADHD, and some individuals, small minority don't tolerate medication, so there are other treatments also available as needed and if needed. And that can include skill development, individual therapy, not for the ADHD, but for the other things that go with ADHD, issues with self-esteem, other disorders that might be present, anxiety, depression, which are common. And then an increasing one, which I would encourage perhaps employers to think about, at least in terms of recommendation, if not facilitating, is an increasing treatment for adult ADHD in the form of coaching. You're probably all familiar with executive coaching, which helps executives sort of do a better job of managing and organizing their lives. That's applied with specialty ADHD coaches to adults with ADHD to help them sort of learn strategies to manage and deal with their ADHD to the extent it's not treated or dealt with medication. So this is the effect of medication. This is how it's supposed to work on the brain. Stimulants work. Remember I said that there's at least one area, multiple areas in the brain that are underactive in individuals who have ADHD. The medications work by stimulating those areas of the brain that are underactive. It normalizes the activity of the brain. Often a question asked is, why would you give somebody who appears to be hyperactive a stimulant medication? It works by stimulating the braking system and the tuning system, the frontal lobe. It's not intended to control individuals, it's intended to return self-control. You can still run around, but now you can also sit still. A new option available to you on medication. So let's talk about medication briefly. In thinking through this, I'm thinking, what would I want you to know about medication in your position, and what would I know my colleagues want you to know about medication? And I think there's probably three messages I want to make sure I bring home today for you as it relates to medication treatment of ADHD. In doing so, I want to give you briefly a background of medication treatment in Canada at least. Up until the 80s, we had nothing but short-acting medications such as Ritalin and Dexedrine, which worked in an immediate way, very short-acting medications. They had to be taken 3 times a day to cover the day because people have ADHD all day long. They worked very well. There's no concerns with the effectiveness of these medications. They work very well. The problems were with the fact that they had to be taken 3 times a day. For people with memory problems, that's a challenge. There is issues around abuse. Everybody's aware of the abuse potential of Ritalin and Dexedrine. And there was issues around tolerability. In order to get the effect, this was what's happening in the blood stream of an individual who's taking medication 3 times a day. It's peaking higher than it needs to peak to get the effect, and then it's dipping down below the effective level at times, and so you've got the ups and downs. So the field got quite excited in the 80s when along came Ritalin slow release, which was a slow release version of Ritalin intended to last longer without the challenges. And this is the blood profile of an individual who has taken the equivalent dose of Ritalin slow release. Why is that important? Well, it turns out Ritalin slow release really doesn't work very well, which was surprising. Why would it not work as well? It's slow release. You can see you got the same area, the same amount of medications getting into the system. Why is it not working as well? Why does it end up only working a brief period of time when it's a slow release? Well, it turns out, further research shows that what matters in terms of how long a medication, especially methylphenidate, to treat ADHD is going to work is the time it takes to get to the maximum concentration. In other words, it's not a concentration effect, it's a ramp effect. How long is the ramp? Ritalin 3 times a day works this long because that's the length of the ramp. Slow release works not much longer than a single dose of Ritalin immediate release because of the ramp effect. So what matters in terms of duration of effect is the time it takes to the maximum concentration or the length of the ramp. Well, along came another medication in 2003, the first true long-acting medication available to treat ADHD. And it worked, Concerta. So we've got, actually I'm going to just take I'm going to talk about non-stimulants very briefly, but think about, this is how you should think about ADHD medications. There's non-stimulants, which don't work as well as stimulants, and then there's stimulants, but there's two kinds of stimulants, methylphenidate and dextroamphetamine, and then there are various products in those categories. So Concerta was the first long-acting ADHD medication that was truly long-acting. It works, interestingly, this is just one example of a novel delivery system for ADHD medication. 22% of the medication is immediate release. It's on the outer shell, it's a hard shell. And the rest of it works by osmosis, where water gets in here, expands a compartment, which over time pushes out the medication through a laser hole in the end. Very interesting. Why is that important? It's important because the result is that it works to mimic the 3 times a day Ritalin immediate release in terms of the blood profile, resulting in at least equal, data suggesting better efficacy than Ritalin immediate release. It does last 12 hours through the day. The hard shell makes it very difficult, close to impossible, to access in terms of abuse. It's not abused like Ritalin SR and IRR. And the tolerability is better because you don't have unnecessary peaks and troughs through the day, so people tolerate it much better. So that excited the field, and we ended up with more long-acting medications available over time as well. Interestingly, this surprised the field. Not only does it work as well as immediate release methylphenidate or Ritalin, but Concerta, Oros methylphenidate, Oros referring to that delivery system, is more likely to achieve remission in individuals who have ADHD. People taking equivalent doses of Ritalin 3 times a day and Concerta, they're far more likely with Concerta to achieve full resolution of their ADHD symptoms, meaning, by this definition, elimination of their ADHD is more likely. I'm just showing you a couple of many slides I could show you. Again, Ritalin 3 times a day compared to Concerta once a day, much more effective in the evening for driving, a very important safety issue for adolescents and adults in terms of management of their ADHD. So there is no question. And what I'm telling you here today about medications, you will not find an ADHD expert in Canada who disagrees with what I'm saying. So I'm not saying something that's out there. This is standard messaging for ADHD treatment. So message number 1. When we're talking about the medications that are available to treat ADHD, methylphenidate products, dextroamphetamine products, and even non-stimulant medications, the gold standard currently is long-acting medications. And we know long-acting stimulant medications work better than non-stimulant medications. That's known. The gold standard for ADHD treatment is long-acting stimulant medications. Another issue, we talked about methylphenidate and dextroamphetamine products. They tend to be different products. Stimulant medications to treat ADHD are not interchangeable. There's about 45% of individuals who are preferential responders. They might respond to dextroamphetamine and not to methylphenidate, or vice versa. So message number 2 is that every medication does not work for every individual who has ADHD. They need long-acting stimulant medications, and covering one or the other does not cover everyone. You're going to have about 45% of people who are not optimally treated if only one or the other is covered. What about generics? I'm going to tell you, I never pay attention to generics. Generics are 99.5% of the time, 99.9% of the time, the same as brand name products, in my understanding as a physician. Is that the case here? We have some information whether that's the case or not. It turns out that Health Canada's decision about whether a generic product is biologically equivalent to a reference product is based on two factors alone. Is the purported generic product within 20% of the total amount of medication that's getting into the system, the area under the curve? Is it within 20%? And is the maximum concentration that's ever achieved within 20% of the reference product? So bring that closer to home. If they're within 20%, they're biologically equivalent. So Rob and Brent are the same height. Yeah, they're twins. According to Health Canada, they're twins. What it doesn't ask is how long does it take to get to maximum concentration, because that does not matter 99.9% of the time. I already explained to you, with stimulant medications to treat ADHD, it does matter, because it's the time to maximum concentration that makes the difference between it lasting all day and not, and being effective and not in terms of tolerability. So Health Canada, according to Health Canada, they're equivalent if only those two measures are met. This is the generic version of Concerta, the Teva methylphenidate ERC. This is the blood profile of an individual who takes the generic equivalent of Concerta through the day. You can see it mimics Ritalin SR. It does not mimic Concerta in terms of the blood profile. And it turns out that that's the effect. It is the same as Ritalin SR. I encourage you to ask any ADHD clinical expert across Canada. This is what you will hear. It is exactly the same as Ritalin SR in terms of its tolerability, its effectiveness, and its safety profile. It is made up the same as Ritalin SR, even though it is shaped to look like Concerta. It's made up of the same waxy matrix. You can crush it and it's accessible in the same way. So according to Health Canada's definition, actually Ritalin SR is a generic version of Concerta, which any clinician will tell you just does not make sense. The data is that it doesn't work the same. Judy Van Stralen in Ontario did a review showing that of individuals who were switched inadvertently from Concerta to the generic product, 87% of them destabilized. It's consistent with my experience as well. Health Canada's data around adverse events indicates that there's a clear difference between them in terms of the frequency of adverse events on the generic product versus so it's consistent with what we would predict given the blood profiles. Again, inaccessible in terms of generic access for abuse, whereas this is generic Concerta, this is Ritalin SR, you crush it, you snort it, inject it, whatever have you. It is certainly not equivalent. So Health Canada suggests, based on these two criteria, which make sense almost all the time, but don't make sense for stimulant medications, that they're equivalent, and clinicians would suggest that this just does not make sense, and that there shouldn't be substitution between the two. So wrapping up, biologically equivalent does not mean therapeutically equivalent. FDA's our neighbors down south concluded, based on all of this data, that there shouldn't be an automatic approval, and that they should be looking at more than just those two. The FDA believes they should be looking at more than those two numbers to decide if something is equivalent to a methylphenidate product, because the interchangeability just doesn't occur automatically. So, in summary, my messages for you really are that ADHD really needs to be understood as a frequent disorder that's present in adults in the general population. It can impact individuals functioning in their lives and in the workplace. It would be valuable if employers were able to recognize it for what it is, view it through the correct lens, recognize that an individual who's struggling with ADHD may not be aware they're struggling with ADHD, and encouraging exploration of reasons why an individual is having the difficulties related to attention and distractibility that they are. And that treatment almost always, I say almost always to be conservative, it always includes medication, and that typically is with a long-acting stimulant medication. Stimulant medications are not interchangeable with one another. Some individuals will respond to this one and not this one, and vice versa. And as I've shown you with the clear information around generic products, as it relates to stimulant medications currently in Canada, they are not interchangeable. And from a clinical perspective, it does not make sense to mandatorily require substitution, because they're two different products that don't work the same, don't have the same safety profile, and aren't as likely to be helpful. So thank you for your attention.